and I'm subcontracted by the State Office of Rural Health to assist with the MBQuip project. And we have, I think, what you will find to be a very helpful presentation today. The slide deck was sent out this morning about 8:35 to those that were invited. I encourage you to pull up that presentation. There's a lot of great detail in here that I know you will want. I want to take a minute to really thank the State Office of Rural Health team for their countless hours at the Indiana State Department of Health Call Center. Ann Alley, Joyce Sillenworth, and David Conrad have spent numerous hours there fielding calls and answering questions. Also want to thank Allie Orwig for supporting Zoom today. Allie's with the Indiana Rural Health Association, and in a bit she'll also kind of remind the group about some funding opportunities. And our presentation today comes from Charles James with North American Healthcare Management Services. Accompanying him is Elizabeth Burrows. I know that many of you are familiar with Elizabeth. She does a lot of work across the state and has done a great job in helping rural health centers and just FQHCs and just different areas with reimbursement. This is part 2 of a behavioral health billing webinar and just integrating behavioral health. Part 1 was presented by Greene County General Hospital, so big thanks to their rural health clinic there in sharing their progress and successes. And so we'll just build on that information today. And so I'll turn everything over to Elizabeth and let her do some introductions. And so Elizabeth, I'll turn it over to you.
Thanks, Becky. Yeah, we definitely do want to say thank you to Ann Alley and her continued support and her team's support at Indiana State Department of Health. It has been through the SHIP program that I got to work with a lot of you, and many of you have asked for help with specifically behavioral health integration. Following up to that, I spoke with Ann about getting some extra technical assistance for behavioral health integration. So I am here. You can email me. If you don't have my information, you can definitely write Becky and she'll get you in contact with me to come out and do technical assistance. I've been helping a lot of RHCs with policies, setting up your forms, getting you guys partnered with other RHCs that are doing this, and fixing some billing issues. So please let me know how I can assist. I know there's a lot that we still have left to do, but again, I think when I started in this program about 2 years ago, there was maybe one RHC doing behavioral health, and now we're looking at a lot more doing it now and a lot more looking to do it. As you can tell, we have a great turnout on today's call. So really excited about many of the opportunities. When we asked Charles to do this, it was kind of before all the craziness had hit of COVID-19, but he has been gracious enough to update his presentation and make it tailored to the guidance that came out, I believe, on Friday afternoon from CMS. He's already incorporated that. Also, if you haven't met Charles, I think many of you know him from speaking at the Indiana Rural Health Association meetings. Charles is also on the board of the National Association of Rural Health Clinics, as well as president-elect of the Illinois Rural Health Association. So he comes very highly recommended. I've been able to work with him, and I know some of your RHCs he's worked with. So I asked him to present on this. This was something he broached at the NRHA meeting down in French Lick last summer. We talked a little bit about the new providers that had just been approved, including behavioral health and chiropractors. And so this is a follow-up. If you have questions, we ask that you just let Charles talk through his presentation. If you have questions, please put them in the chat box. Becky and I are glad to field those at the end of the presentation. We hope we have some time. And if not, there will be contact information for Becky, Charles, or myself. As a quick addition today, we thank Allie for being so flexible. Allie Orwig, who's assisting Becky in hosting this Zoom platform, is going to speak a little bit about how NRHA is involved in the FCC COVID-19 telehealth funding. So right now I'm going to turn it over to Allie for some quick information on that.
Thank you, Elizabeth. As many of you may know, the RHCA has been a long-standing participant in the FCC's Healthcare Connect Fund that was previously the Rural Health Pilot Program. We were the consortium in the state of Indiana that made that funding available. Now the FCC has just released an extra $200 million for funding of provision of telehealth as it specifically relates to COVID-19. If you are doing any services through telehealth that help patients with COVID-19, screening for COVID-19 at all, there is a potential for you to get some funding to pay for software, bandwidth, just a ton of things that haven't been previously eligible for funding. And even if you're only doing some telehealth for COVID-19 patients, the funding is still available to you because there is a section where you say how many you'll be screening or serving with COVID-19 and how many other patients will be receiving care through telehealth. So it's currently on a first come, first served basis, though there are some merit-based criteria that they're building in. And we are certainly available to advise on how to get those applications in. For anybody that has participated in the Healthcare Connect Fund or pilot program with the Indiana Rural Health Association or the Indiana Telehealth Network, we already have done some of the work for you, so we can save you some time. They have already sent out the first round of funding from applications that have come in, so they're moving very, very quickly on this. And it is retroactive back to March 13th. So just because you've already purchased and implemented services for telehealth doesn't mean that you are out of the running for this funding. So I'm going to put my email address in the chat window for everybody. If you do have any questions, please reach out at any time. We're happy to talk you through it. Thank you.
Thanks so much, Allie, and we appreciate your assistance. And I know Becky, myself, and ISDH also are glad to assist. We want Indiana to, definitely get as much of the federal dollars as we can. And now, without further ado, we're going to turn it over to our main speaker, Charles, to go through the presentation. Thank you, Charles.
Great, thank you very much. I'm so happy to be here. I know we've all been dealing with quite a bit, and I hope everyone is healthy and staying a little bit sane. Got a new normal, right? I've spent a significant amount of time traveling around the state of Indiana. I love the great state of Indiana. I've got some Hoosier street cred because my wife was born in Vincennes, Indiana at Good Sam Hospital. So I will particularly miss the French Lick gig this summer. A virtual conference, or I think it's maybe scheduled for later, excuse me, I don't want to misspeak. But boy, we like the French Lick gig, and I appreciate the invitation to come and speak to you all on this topic. It's difficult to make a basic rural health clinic presentation a lot of times, especially when we're talking about behavioral health, and now in the context of telehealth, it's just difficult to make something simple and straightforward. So what I hope to do is make a complicated topic straightforward and really give a good understanding of what the behavioral health benefits there are out there for our patients and out of our rural health clinics and FQHC. Some of the description of the presentation was a little off. I was going to differentiate, quote unquote, between RHC and FQHC. But really, our guidance is in many ways uniform. At the Medicare level, we both operate off the Medicare Benefit Policy Manual and the Claims Processing Manual. It's chapter 13 and 9, respectively. I have those resources cited at the end of the presentation. And at the Indiana, at the IHCP level, the guidance is also combined for RHC and FQHC. And a side note, I don't want to take up too much time with narrative, that the telehealth guidance from Medicare did just come out on Friday. There are some holes in it. And we in the consultant community have done our best to plug those holes within the framework that we know about. And I'll do my best to point those out as we go along. So why don't we go ahead and dig in? So I want to go over some just RHC basics. And I think we really need a just core understanding of some of the premises of RHC in order to understand the behavioral health component. I did my best to keep this concise in Medicare and IHCP guidance and distinguishing between those. There's a lot of commonality in that. And then finally, I would like to promote really care management services and behavioral health integration under the auspices of that care management. And then hopefully leave some time for questions. But I absolutely want to keep myself available via email or whatever other context to make sure all of your questions get answered. So an RHC is a clinic that has a certification or an accreditation to receive special Medicare and Medicaid reimbursement. And that reimbursement is cost-based. And we get a rural health clinic encounter for every patient that we see, really regardless of how few or how many services are rendered. And I'm going to show some basic definitions of what we have to do to have a legitimate RHC encounter. 51% of our clinic services, and this is vitally important in a rural health clinic context, this has received a lot of attention, particularly in addiction treatment in the context of that. Addiction treatment is really primary care now almost, right? And we have a problem because in rural health clinics, we have to be 51% primary care and no more than 49% of our cumulative provider hours. We have a lot of 50% and 50 numbers in rural health, but no more than 49% of our cumulative provider hours can be behavioral health. In the rural health clinic statute, which we've been trying to modify, it says rural health clinic cannot primarily be engaged in behavioral health services, I paraphrase. So 49% of cumulative provider hours on this one. And the purpose of the program is to improve access to primary care. We can offer behavioral health in a rural health clinic. We cannot be primarily a behavioral health entity, if that makes sense. In normal times, we have a 50%, here's another 50%. We have to be staffed with a quote unquote mid-level provider. I use the term mid-level because it is, for better or worse, throughout the guidance. And where I can, I quote guidance. I don't want to recreate it. I just try to pick out the most cogent parts. So 51% primary care, no more than 49% of our clinic hours, 49% of our provider hours can be behavioral health. And our 50% of the mid-level practitioner, that is based on clinic hours, to be perfectly confusing. So I don't want to dwell on that too much. Just know we have some of those staffing thresholds that we have to deal with as rural health clinics. The point of rural health clinic certification is much less advantageous on the independent side. Independents are capped at $86.31 for that RHC encounter rate. For this reason, we've had a big flood, a big migration to provider-based hospital, and we're going to talk about that in a second. But that all-inclusive rate is calculated by the MAC by dividing total allowable costs by the total number of all patients, and that represents our cost per patient. And here's the important part: productivity, payment limits, and other factors are considered in the calculation. One of the other factors is the hospital that owns the rural health clinic. We'll see that momentarily. Independents are our old country docs. Now they're country nurse practitioners and PAs largely, but our independent clinics are those that really are not associated with another hospital. We haven't formally done the paper process to associate that with the parent entity. I know some of you on the call today are familiar with that conversation. We're paid at the current RHC cap as an independent. The whole other presentation on what we've been trying to do to moderate that. And we file our own cost report as an independent. Failure to file a timely cost report results in hate mail and no money. So file your cost report. This is the other payment limit I mentioned, provider-based RHCs. A provider-based RHC that is owned by a hospital with fewer than 50 beds qualifies for uncapped RHC encounter rates. Any provider-based RHC associated with a entity greater than 50 beds just is capped as an independent. The provider-based rate is set on the parent hospital cost report. We bill claims to the MAC that services the parent entity. And I had one more really amazing point to make, and this escaped me, so we'll move on. The encounter definition is we have to have a medically necessary medical or mental health, behavioral health visit, or a qualified preventive health visit. And under normal circumstances, the visit must be face-to-face, one-on-one encounter between the patient and physician. So of course, that's a big component of what we have waived. Nurse practitioner, let me make this screen a little smaller, there we go. Face-to-face encounter, medically necessary, behavioral health visit, now I'm getting ADD on here. Medically necessary, behavioral health, qualified preventive visit, face-to-face. Encounter between the patient and physician, nurse practitioner, PA. We're gonna modify that in a second with our COVID-19 guidance. Face-to-face encounter with one of our RHC providers. Under normal circumstances, of course, here are our providers, of which, again, at the core in the statute, in the legislation, always is the ability to bill a clinical psychologist and a licensed clinical social worker at the Medicare level for a rural health clinic encounter. We can also include these other providers listed here, chiropractic, dentistry, optometry, podiatry. Don't see a ton of those in our rural health clinics. And of course, at Medicare level, there's a specific dental health exclusion. But again, that's fodder for an additional conversation. Here's the big curveball that we got on Friday. This is a quote. I do not have this in writing, unfortunately. The quote is that any service provided as a distant site telehealth service, if I got my slides out of order here, I may have, I've got my distant site guidance coming up here. But any service provided as a distant site service, and they reference the physician fee schedule CPT list, which is a super oddity in rural health clinic. Any health practitioner working for the RHC, their FQHC, within their scope of service, scope of practice, the RHC bills this as a distant site. What they're saying is any provider adequately licensed in the state, and in this case, including RNs, if within the RN scope of practice. So as a side note, in RHC, all of a sudden during the this is during the emergency only. Any licensed provider that takes it down to an LPN or even a certified MA, in my view, is very confusing guidance because this is very new for us. But this is during the emergency. We have enormous flexibility in the providers for whom we can bill an encounter. This is telehealth only for these nursing visits. This is a big curveball for a lot of rural health clinic people that are familiar with this stuff right now. For behavioral health qualifying visits, under normal circumstances, we also have a qualifying visit list. I chose not to go into the qualifying visit list in great depth today. But note, part of our guidance we got on Friday refers to a CMS telehealth service list, which is relevant for telehealth, and a behavioral and our qualifying visit list, which contains behavioral health qualifying visits. So this is a part of that list. We can see these in normal circumstances. These are the codes that would qualify as a face-to-face encounter in the clinic. And Medicare has expanded that list somewhat to additional services that we can provide via telehealth, but these are what we're thinking about. We deal with revenue codes, So our behavioral health services are going to be billed on a UBO4. We're going to use revenue code 900 for behavioral health services. Our claim form, here's some claim form information. I'm not sure if we have providers on here, but you may not care about this, but our billers, most of you are probably already familiar with these details. We have multiple encounters that are allowed. And here's what I want to emphasize, here's why I allow multiple encounters. Because I get a lot of feedback that we think that because we've had a clinic visit, perhaps we can't also have a behavioral health visit. Or if we have a behavioral health visit, we can't also have X or Y. Here are the conditions under which we can have multiple encounters. The patient subsequent to they come in the morning, gets sick, or excuse me, we treat them in the morning for perhaps a chronic condition or an injury. And they come back in the afternoon for a second diagnosis or treatment. We have 2 visits. If the patient has any of those visits, any kind of visit, medical visit and a behavioral health visit on the same day, we have 2 visits unequivocally, never any question about it. 2 visits. You got to get them on the same claim form. That can be a trick. So they have to be posted together and outbound on the claim together. But behavioral health and a medical visit are separate encounters. We get paid 2 AIRs for those services. So here's the guidance I wanted to say. So for RHCs, we did not have distant site guidance. What that means is, as RHCs, we could not function as, with the RHC provider in the clinic, has their cell phone, communicates with the patient in their home. We could not do that. We were statutorily prohibited from doing that. The CARES Act came out on March 27, 2020, signed into law. Section 3704 authorized RHC and FQHC. The guidance is combined. Medicare requires interactive audio and video, and here's a big, huge, confusing factor. Medicare and IHCP, for that matter, consider telemedicine a little different from telehealth visits. So when we use the term visit, we're really talking about telemedicine between a provider and the patient. That telemedicine visit requires this interactive audio video. We may have a telehealth visit via other means, i.e. a phone call, but that's a different service. RHCs and FQHCs can immediately provide these services, even though on March 27, we didn't know how we were going to get paid for those. So March 27, 2020, the CARES Act signed into law. Up until April 17th, we did not have the guidance on how to accomplish this at the Medicare level, so that if including behavioral health providers in this, behavioral health provider is at their home, we can do this. Even if they're under clinic time, we can do this. Or if they're at the clinic, we now have the ability back to January 27. And so between January 27 and June 30, we're going to have 2 different mechanisms we're going to have to deal with here. So for now, January 27 to June 30, we're going to amend all of our E&M services, including those qualifying behavioral health visits, with the 95 modifier. The 95 modifier implies and requires real-time synchronous. That means we can see each other back and forth, just like we are on this camera right now on my microphone. RHCs and FQHCs will be paid their all-inclusive rate, FQHCs their PPS, during the emergency period only. These claims will be automatically, first of all, it's important to note, these will pay at the AIR. Will pay at the AIR. So that encounter rate, you're going to get the AIR out of this. Medicare is going to come back and reprocess those claims, however, at the telehealth rate of $92. Medicare gave us a composite telehealth rate of $92. They did not want us to get our AIR going forward. We have a composite telehealth rate of $92. I'm not going to spend time on describing the composite rate right now, but just know it's a composite rate. They don't get the AIR. But we don't need, and I'm going to show you here. We're going to submit E&M with 95. They're going to pay at the AIR. Medicare's going to reprocess, take part of that back down to $92. Yes, if you're provider-based, they're going to take money back. Correct. We don't need to reprocess it, resend the claims for them to take our money back. They're just going to come get it. The glory of electronic funds transfer, right? We're going to bill RHC telehealth visits the same as we would bill for an in-person visit, and we're going to use the modifier 95 on the claim to signify telehealth. This absolutely includes all of our behavioral health providers, unequivocally. The second phase of this will be July 1, 2020 through the end of the emergency. We're going to get this G2025 code. We will use that for the distance site services. So after July 1, we won't use E&M and modifier 95. We'll use G2025. These will pay at the $92 rate. We assume we'll get some further billing instructions. And this is only for distance site telehealth services, RHC and FQHCs during the emergency. Okay. So a super abbreviated version of what I would normally go through on a basic RHC billing presentation. So I'm really just trying to get to the highlights, not do a deep dive on rural health clinic everything, really focus on behavioral health. This is what our claim example would look like to Medicare. 900 modifier, relevant HCPCS code. See, we have the CG in 95, so that answers our question. It's a bit of conjecture. This is one of the holes we're filling in. There's been huge variation in guidance on whether or not we include the CG modifier with the 95 modifier. We healthcare geeks put our head together and decided the only way these claims are going to pay in our MAC is if they have a CG modifier. So I have to say, put an asterisk, please. That's a bit of an educated guess, but I already am having reports back of people, telehealth claims rejecting without the CG modifier on. We're going to report one service line item per behavioral health encounter with the 900 revenue code. Here's what that same encounter looks like if the patient also had a clinic E&M. For all of you billing specialists out there, this is about the only time we're going to use the CG modifier on 2 line items. Almost the only time. I can't think of another time we would do that. If we had a subsequent illness or injury, we're still using modifier 59, so we would not do it then. We can see on our, one thing on a webinar is I can't point to my screen as well and indicate what I'm pointing at, but we see here the evaluation and management code, CG95, behavioral health code. I just use random pharmacological management. We could use any of those 7 codes here. And again, notice 2 CG modifiers, fairly unique. Now, very important detail here. Very important detail. We all make our living mixing words and policy, right? Look at the first line of that. This is not in. This is not. This is IHCP. This is Medicaid. This is not strictly COVID related. In the, look at the reference here, as of October 1, 2019. So some of your policy heavy hitters, and I may have a secret crush on Seema Varma. It's a weakness I have, I'm sorry. And but they know. So at the Indiana level, you all have been out front in a lot of these policy provisions. And as of October 1, look at that. FQHC encounter, valid encounter is defined as face-to-face, either in person or via telemedicine. Amen. Wonderful. Between an IHCP member and a qualified practitioner, C rendering providers, we at the IHCP level have not had the same provider waiver, to my knowledge, that Medicare has done. So that provider waiver that any provider can see a patient only applies to Medicare. Another big difference down here on the bottom, some of our billers may already know this, that are, of course, sorry, I can't let things go by and not correct them when I see them. IHCP telehealth or IHCP rural health clinic encounters go on a 1500, so they're billed on a professional claim. That's very important, because on our professional claims, we will have a place of service to deal with, where we do not have a place of service to deal with on our Medicare claims because they're a UB04. And let's get way down in the weeds for some of us. But T1015 on a 1500, oh, darn it. I also killed another slide in here. We have to have the detail of what is also rendered with that. So we're going to report the T1015 and the appropriate evaluation and management code that goes with this, including our behavioral health codes. Our qualified providers in Indiana are clinical psychologists, clinical social work. I'm, of course, singling out our behavioral health providers. These are the behavioral health telemedicine service codes that are on the IHCP telemedicine service code list. I believe these would also be valid encounters if they're face-to-face.
And
So
just to interject for 1 second, the list of available providers does change on July 1 of this year to expand out. So it's not just clinical psychologists and just clinical social workers. It will expand out to master's level and licensed therapists of all kinds. We'll make sure to get you training and information once that starts. That's been passed by our legislature, but again, does not go into effect until July 1 of 2020.
That is really good to know, because a question I get a lot of times is that LPC, master's level counselor, and at the Medicare level, they do not allow those under normal circumstances. But listen to what Elizabeth just said. As of July 1, those are, wow, man, even right now, is that a valid licensed provider, the LPC, or is there not valid licensed provider until July 1? So as of July 1.
It's questionable. To be safe, I'm saying the July 1 is when it goes into effect. But again, we're still waiting for additional guidance on that. But
it's always a big question, and that would be a big deal. And at the Medicare level, up where they have open providers up to any providers, one of their big intents with doing that is on therapists of all kinds. Absolutely. So as long as they're licensed in the state, that will be the driver. Thank you for that input. That was a question. I didn't want to include anything in that because it often is a very confusing issue. So thank you. Telehealth for Medicare, IHCP can be provided using any technology that allows for real interactive consultation between the patient and provider. So this is for the telehealth emergency. Normally, I think phones were not included, but for the public health emergency, we can use the telephone. Just for the record, and this is where I did want to go today, on the virtual check-ins, telephone conversations at Medicare and at the IHCP level would probably be virtual check-ins. So Medicare limits our phone use to a virtual check-in. Our telemedicine, our billing a visit would have to be via interactive audio. So for telehealth during the COVID emergency, IHCP has opened up this up to telephones which normally they had not been, but IHCP does not consider emails and text messages part of a telehealth visit. So they are including voice only, but not including email and text messages as a telehealth visit. Got these billing guidelines. This is what the slide I was looking for, that second phrase right there. We've got to use the T1015 and our appropriate CPT code and HCPCS procedure codes that were rendered during the visit. If I come over here and I get up on my screen here, I've got all of the IHCP guidance here on my screen, and I can include these. These are all out there. Here's the emergency bulletin that came out. Yes?
Are you on a split screen by any chance?
Oh, you know what? I bet I'm just open to maybe viewing my presentation. So sorry about that.
Yep.
So I'll skip that. There are a bunch of PDFs that are great. All this information pulled straight from the PDF. The valid list of procedure codes was one of the PDFs I just demonstrated, and they're pretty similar with the Medicare telehealth codes that I've talked about. Here's our place of service, where on IHCP, we have place of service that we have to put on the claim. We're going to use O2 with modifier 95 on our on the CPT codes that go with the service. Ooh, I need to clarify that a little bit. Those go on the T1015 or on the CPT detail. But since it's 1500 as opposed to Medicare, where there is no place of service, we do have a place of service O2 to deal with because we bill on a 1500 for our IHCP claims. Here's a big thing I really want to be sure and get some emphasis on. I know we kind of rushed through a lot of that. There's a lot of information. I want to talk about care management services. When I talk about care management services, coordination of care services, we're talking about chronic care management services, right? There is a huge behavioral health integration component to this. Part of the reason for care management services, and when we want to talk about what telephone visits are included, what text messages, et cetera, may be included on a care management, it goes to time spent with the patient. Huge behavioral health integration component. Real quick note, we have 2 codes only for rural health clinics. That's G0511, and this is for FQHCs as well. G0511 and G0512. On that composite code that we talked about of virtual check-ins here, where I see the G0511, see where it's set for the national average of 99490, 99487, 99484. That's a composite code. The national average for 2019 came out to 6703. I could not confirm the 2020 payment, and I haven't had time to look up the fee schedules, but I think it went up to maybe $69, something like that. Care management services, we have a BHI component of our behavioral health integration component of our care management services. So effective January 1 of 2018, RHCs and FQHCs are paid for behavioral health integration services with a minimum of 20 minutes qualifying general BHI service in a calendar month to our behavioral health patients. It qualifies for, let's see, one or more new or one or more. So it's not like the clinical care management where you have to have 2 or more. Behavioral health integration is 1 or more new or pre-existing behavioral health or psychiatric conditions being treated by the RHC or FQHC primary care provider, including substance abuse disorders, that in the clinical judgment of the RHC provider warrants behavioral health integration services. Sorry to read to you, but that's very important language right there. Including substance abuse disorders that in the clinical judgment of the RHC provider warrants behavioral health services. Fantastic benefit here. So option A is what most of us know as the behavioral health, or as the care management service benefit. Option B is what we have as behavioral health providers. Any behavioral health psychiatric condition. So what I just said. So G0511 qualifies for option B. For option B, we have to have an initial assessment with applicable validated rating scales, behavioral health planning, revision for patients not progressing, coordination with other therapy resources, other treatment resources, and continuity of care within our team. I don't want to go through all of these. These are standard care management requirements, but we see we have to have structured recording. We have to put it in our EHR. There's some other things I don't want to spend a lot of time on. I want to talk to, we have to get consent is a very important component of the care management service. This is G0511. I want to really emphasize the second one, G0512. So in addition, these can be billed in addition to an encounter or by themselves. We don't have to have a valid encounter to bill these. This is Medicare only. We have to have seen the patient within the last year, but we have 70 minutes of care time in the first month and at least 60 minutes in subsequent calendar months of psychiatric coordination of care management services under the direction, so the RHC provider is involved. We have to have a behavioral health care manager, and we have to have this psychiatric care team. So we can, like I said here, we can bill this alone. We can bill it once per month. We can only have one provider doing it. It is a composite code, but look at the 2020 payment rate is 145. I think this went up to 150-ish for 2020. It's a 2019 payment rate. 145.96. That's a pretty nice payment for that, honestly. I think. Editorial. So more for independents, that is more than the cap. Again, this is not an encounter payment, it's a chronic care management service payment. And these rates get updated annually, and co-insurance does apply. Now, during the emergency, another provision, we can waive co-insurance for non-COVID related. We have the ability to waive co-insurance even for non-COVID related items. We have to have our RHC provider who directs the behavioral health care manager, oversees care, and collaborates through ongoing oversight and management. What some of these means, we are allowed to fill in some of the gaps ourselves. These are the frameworks we have to live in. The behavioral health care manager is a designated individual in our clinic with formal behavioral health training, including a social worker, a nurse, or a psychologist with a minimum bachelor's degree in behavioral health. Or as a clinician with behavioral health training, look at that, such as RNs and LPNs. So our behavioral health care manager can be an RN or an LPN. The behavioral health manager can furnish both face-to-face and non-face-to-face services under general supervision. And here's some additional information about them. And we have to have a psychiatric consultant. This is not the person who's necessarily seeing the patients, but they help oversee the program, participate in regular reviews of coordination of care services, advises the RHC provider on diagnoses, option for resolving issues, et cetera, et cetera. I'm very much not a behavioral health kind of mind. You know, I'm just an MBA type of guy who reads Medicare policies, right? Manages negative interactions, facilitates referral. So I really, that's a lot of information in a really short amount of time. I wanted to hit the highlights and get across that there is a significant behavioral health component to rural health clinic under Medicare and Medicaid in Indiana. We've got a lot of flexibility. I know nobody, no sites I know of are taking advantage of the psychiatric, the G0512, this benefit here. I know of no one doing that. So I would love to hear about someone implementing this and taking advantage of it. I think it's a really important benefit. So ultimately, that's what I wanted to get through today. So I've got references. I encourage.
Charles, we have a couple questions, if
Yes,
you
please.
don't mind.
Excellent.
That have came through. What is the reimbursement rate for the IHCP telemedicine visits? Are they mirroring the $92 per visit that's being reimbursed for Medicare telehealth?
For Medicaid, IHCP, I'm sorry, I didn't
Yes,
make that explicit.
Medicaid telemedicine.
Those are encounter payments.
So you're getting your full encounter payment for clarification. So that ought to make, yep, that's what Charles says. I agree. So that ought to make everybody real happy right now.
I mean, it's right there in the encounter definition.
Perfect.
That's why I emphasize the definition of encounter includes that telemedicine visit.
Perfect. So we need to take advantage of that. Can you clarify how IHCP, RHC claims should bill? Do they use the T code or not? What modifiers, question mark?
Say that, I'm sorry, say the first part again.
Can you clarify how IHCP, so Indiana Medicaid, RHC claims should be billed? What modifiers do they use?
Let me get back to the slide. We're going to use, for if you're a rural health clinic, we're going to have, if it's telehealth, we're going to have O2 modifier 95. So let's see, I can't see that. With the CPT codes for the allowable services during the what I need to clarify and understand here is if the modifier goes on the T1015 or all of the services. I probably put it on all of the services, but that's one question I would have with that.
Okay, we can open it up to, do we have any other questions that you guys can unmute yourselves and ask at this time?
Charles, I had a question that was sent to me. Do you have any direction around depression screening, such as if a clinic would use a PHQ-9? Any billing suggestions there?
The depression screening, I believe, is a Medicare preventive screening. I don't recall the code right off the top of my head, but that is a Medicare preventive screening. So that would be a standalone encounter. If that happened by itself, you could get the AIR. Well, and actually, if it happened with another visit, if that depression screening, that's not, I don't think that's on the QVL for psychiatric. Regardless, that's an encounter. Depression screening is an encounter. I think it's a standalone encounter at the Medicare level, and that should qualify for the encounter rate.
Thanks. I think that's often missed, but thank you.
Sorry, Becky. As a follow-up to the earlier question about how we bill Indiana Medicaid, I followed up with her. She said, so do we use the T code on all Medicaid rural health clinic claims?
Yes.
Okay.
And if it's face-to-face in the clinic, you're just going to use a regular place of service 72 and no modifiers, to my knowledge. If it's a telehealth visit, that's where the place of service 02 and modifier 95 come in for telehealth visits. Place of service 72, patients in person in the clinic. Place of service 02 if the patient is being seen via telehealth.
I've got people really excited, so I'm going to emphasize again, yes, as a provider-based rural health clinic, you can continue to get your AIR, your all-inclusive rate for Medicaid telemedicine visits. So we want to confirm that, yes, that's correct. So please, please take advantage of it. That's a way that this probably isn't what we want publicized, but it's a way, I know a lot of you have been hurting on visits because of COVID-19. This is a way that you can help recoup some of that lost revenue.
It's right there. It's explicit.
There's your documentation. I know the person that's writing me likes her documentation, so you can click that through the slide, through the PDF that we sent, click that link, there you go, or Google that information, IHCP, the policies and procedures, October 1st, you'll have that documentation there. So
So
that's very
that is,
exciting. So again, please use this. These are resources out there to help you. Have your RHCs using these.
and it's pre-COVID. Indiana, Kentucky, Missouri, Louisiana, some other states, I'm not sure off the top of my head, all were way out in front of this and had opened up telehealth to regular encounters as AIR prior to this emergency. This is what we're trying to get at the federal level. This is part of the hang up at the federal level. The feds, CMS, they didn't want to give us open-ended telehealth at the AIR. So if you need to lobby for something, we probably have some politically connected people here, lobby for telemedicine being made permanent at the AIR and stop messing around with all this other business. It needs to be at the AIR, and why should we be any different than anybody else? That's the message.
Agree. Do we have any other questions while we have Charles available here in the last few minutes?
I certainly wish I should have included that slide. There's another slide I could have included, but of course, I wanted to try to keep it to 30, 45 minutes. So,
Becky, do you have any other questions that have came in?
No, I have not. I do not.
All right. Well, then I think we can wrap it up. Again, the presentation will be going out. Again, a big thank you to IRHA for hosting, to Becky Royer and her NBQIP partnership on this, and again to Charles James for making this presentation very clear. If you have questions or follow-up, please email me or Becky Royer. We will get back with you. Or again, there's Charles' information, and you can also write Shelby Hornback at IHA. She'll be glad to get with you. Also, just a final reminder, the FCC money is yours for the taking. Don't get scared by a grant application. Ask for help. It really is self-explanatory. You have any of us here to help you. Indiana needs to get our money for that. We have all our leaders in big positions. Let's take advantage of it while we can. Typically, Indiana is way behind on getting federal dollars. So let's take advantage, hopefully while we can. So thank you all for your participation. If you have questions, let us know. Thanks, everybody. I hope you all have a safe and healthy day.